from fall, and it just goes into a little bit more detail on some of the mechanisms and some of the drugs specifically. So shouldn't really be too much new information here, and we'll go through it relatively quickly. So just to review, atherosclerosis, disease that often leading cause of cardiovascular events in Western countries. So whether it be unstable angina or NSTEMI or STEMI, this is usually the culprit of it. You get some kind of a plaque buildup in the artery, which eventually either constricts it to the point where you're getting symptoms, or it bursts through the vessel wall and causes infarction that way. Generally speaking, the idea is that you have too much cholesterol getting transported to your arteries, and therefore if we can lower that, you can have a better outcome. So the idea is that you have two different transporting systems, low density and high density lipoproteins. One brings cholesterol from the liver to places, and one scavenges for cholesterol, kind of is the easy way to think about the two. And then there's also triglycerides, which are just generally fat made in the body. Usually you see elevated triglycerides go hand in hand with things like high LDL and high diabetes. To get a little bit more advanced, I'm not concerned you really know about this, but there is some extra stuff outside of those particles that we talked about. So there's things called chylomicrons and very low density lipoproteins that deliver energy-rich triacylglycerol, or TAG, to different cells in the body, and you get this broken down into other fatty acids or stored in adipose tissue. So these different aspects can have some other contributing factors, I guess. So the idea is that you aren't just solely reliant on the LDL process, but they all are kind of put together. So LDL is thought of as the last step in everything. So LDL delivers cholesterol to the body. We talked about that already, but VLDL particles get stripped of TAG, which increases their density. These particles get remodeled in the liver by LDL. LDL binds to the LDL receptor, and then that releases cholesterol molecules for use. HDL has, again, the reverse process going on. So excess cholesterol is getting eliminated in the body from the body in the liver, secreted in the bile, or converted in bile salts, and then precursors synthesized by the liver sent out to cholesterol and then returns as HDL. So basically, that's the whole process. There's a whole life cycle involved, which I've got a pretty basic drawing on here as to how it all works together. But again, we're really focused on LDL as our primary biomarker when it comes to drugs, and HDL is something we can use as a screening tool. High HDL is associated generally with better outcomes. Low HDL can be associated with poorer outcomes. Manipulating it pharmacologically hasn't really been shown to be all that effective for doing much. And to review our goals, remember that goals are kind of have been thrown out the window at this point. We don't really have goals specifically. The idea is that you're giving somebody a drug that's going to be beneficial, and aggressively targeting specific LDL cholesterol goals isn't going to be beneficial for the patient. So there's been a lot of studies since the original goals came out looking at these aggressive markers. So if you target less than 100 or even less than 70 in some patients, do you actually get improved outcomes? And they're showing that you don't. So the idea is, why are we giving somebody more drug or higher doses of drugs, putting them at risk for more side effects, when we don't necessarily have to do that? We can get the same outcome without it. Reviewing old guidelines and risk categories. I put these up here because I think people still like to know about this. I think it's worth understanding how the original guidelines, not the original guidelines, but the previous guidelines were set up, and how they looked at different stratifications. So where were we targeting more aggressive therapy, and who was lower risk versus higher risk? A lot of it has to do with comorbidities, things like that are listed down here. So smoking, hypertension, relatives that have had CV events, things like that would be the big ones there. But those different equivalents, depending on how many you have, could put you at a different goal category. But again, this isn't current practice based on the current guidelines. However, you still might have different providers that might still practice that way. It's not necessarily wrong. It's just guidelines are guidelines, right? They're absolute rules. You don't have to follow them, but they give us a good idea for how to practice based on the current evidence that's available. So we talked about this in the fall, but just to reiterate, because I think it's an important, interesting point, make sure we're all on the same page. And the idea is that when 2013 CHEST came out, you had these more aggressive goals, right, that weren't proven. And these guidelines then said, well, let's shift away from the numbers and just focus on treating people. So we say everyone should be on a statin if they meet certain criteria. And some of this was pretty self-explanatory. I think most people would agree with the first 3 bullet points, nothing too crazy there. And the fourth one being the most controversial, saying that anyone with a 7.5% risk or higher is going to be at risk of a heart attack, enough that they should be on a statin regardless. And the calculator we're going to look at here, or that, yes, on the next slide here, will show you that you have a pretty substantial chance of getting that risk up. Trying to actually get out of here. There we go. Pretty substantial chance of getting this risk up above 7.5% if you're at a certain age, regardless of how good your values are. So let me get onto this. There we go. See if this link actually works. Okay. This should be pretty easy to find. There we go. All right, here we go. cvriskcalculator.com sounds pretty legitimate, right? Let's put in a 70-year-old guy. We'll just say their other race. Total cholesterol. So let's say normal total cholesterol. Let's say 175. HDL. We'll say, I don't know, 50. Systolic blood pressure. Diastolic. Treated for high blood pressure? No. Let's just say he's not treated for anything. Let's just see what it calculates to. So 15.3% year risk. So that's just because he's 70. There's really nothing else to it than that. Total cholesterol is normal. HDL is even a little bit above what we'd say is normal. If you get your HDL up a little bit higher, they actually give you a negative risk factor. So then they drop your score. I think it's above 60. They'll put that in there. Blood pressure you can see is normal here. If we added treatment and other things like that onto there, so let's say he's treated for hypertension, but he's controlled, you'd end up seeing this bump even higher. So again, the whole point is you have a 70-year-old guy here, and let's say you don't know much about him other than what I've shown you here, but let's say there isn't anything. He's healthy, doesn't take any medications for anything. Maybe he takes a multivitamin and fish oil. We'll throw that out there. But the point is that he would still be put on a statin based on the current guidelines. So again, controversial, I think, for most people to wrap their heads around why would I treat somebody if they aren't overtly presenting with some sort of symptoms or some sort of a lab value that I can measure. And that's where the guidelines have gotten a little bit confusing, I think, and people were been a little bit apprehensive about doing this is because you might have had a lot of patients before in your practice that wouldn't qualify for statin therapy, and all of a sudden you have a lot of more that do. So something to grapple with as a provider, do you prescribe that or not? And I think it's up to you guys and up to your clinical decisions and up to your discussions with your patients, involve them, of course, in their own healthcare. But the guidelines would say yes, that they would recommend it. So that's really all we have to go on. And I think, in 5-10 years, maybe we'll have new guidelines that say, yeah, we over-aggressively treated people. We saw that people weren't really getting mortality benefits long-term, but we saw a lot more rhabdomyolysis or something like that. So then they pull back. So you never know what's going to happen, but for now, that's what the guidelines would say to do. Okay, so statins are, once again, they're HMG-CoA reductase inhibitors, and this is the rate-limiting step on cholesterol biosynthesis. So these are a cornerstone of high cholesterol treatment. In fact, everything else we're going to talk about is pretty much non-relevant for the most part, with the exception of the PCSK9 inhibitors. Very well-studied drug, probably the most extensively studied class of drugs that's ever existed on the planet. And that's saying something. So statins just really... CV medicine in general has a ton of, it's very evidence-based, right? So hypertension guidelines, cholesterol guidelines, everything is heavily evidence-based. There's a lot of studies that go on in the world of cardiovascular medicine. It's a huge area for research. And statins certainly fall into that category too. So ever since statins came out, people have been thinking of them as miracle drugs more or less because their mortality benefits are so good. And ultimately, that leads to more and more studies, either to replicate the data or say, are we using these to the best of our advantage? Do we have to give people these high doses? Are high doses better than low doses? So there's all types of subsets that people look at to see if statins. And some of the studies are very small and not great, but there's a lot of really robust studies done on statins that show that they have a pretty substantial benefit. So again, very well-studied medication. Useful in both primary and secondary prevention cases. Mechanism, again, we don't fully understand this. This is kind of the core of another core of statin controversy. They lower LDL, that's provable. We can measure that, yes. But regression of atherosclerosis rarely occurs. So usually you might see benefits in a statin patient in as little as 6 months where their risk reduced. So if you look at studies and like a randomized control study on somebody on statin and not, you'll see that the people who are on the statin start to show lower event rates and start to split off from their peers at about that 6-month time mark. That's not really enough time to reduce atherosclerosis, even if you aren't consuming any cholesterol or transporting it. Just physiologically, it doesn't seem like it's possible. So the question is, what exactly is it doing? If it's lowering your cholesterol, maybe preventing the plaque from getting bigger, but it doesn't really help any regression in the short term. So some theories out there are that it stabilizes the plaque itself and prevents it from rupturing through the epithelial lining of the blood vessel, or it reverses endothelial dysfunction, possibly decreased thrombogenicity to decreased ability to form a clot. How all this works as far as how a statin would interfere with some of these mechanisms, I don't know. And I don't think anyone could tell you specifically, yeah, statin has antiplatelet activity. Well, how does it do that? We don't know really for sure. So anyway, there's a lot of mechanisms at play here that might be more beneficial than what meets the eye with a statin, but ongoing evidence hasn't really pinpointed anything specifically. Lots of theories out there. This chart just shows cholesterol and statins, so where we block the synthesis point. And so again, HMG-CoA reductase, end up synthesizing cholesterol, and without it, we can't get to that point. That's the only purpose of this slide. Nothing really else there. Efficacy. So statins are the most potent LDL lowering drugs. They vary in potency and side effects, and usually you get diminishing returns with all of them, meaning the higher dose you go, the lower benefit you get. So starting somebody on a statin is always going to give you, for the most part, the biggest jump in LDL reduction, if we're purely looking at LDL. And then the higher a dose you go, you don't get quite as much bang for your buck, but you still do get some reduction. Decent HDL increases as well. Decent is probably a relative term. Probably should reword that as to some HDL increases, because I don't think any clinical appreciable ability to increase HDL is obtained with a statin. But simvastatin has maybe slightly higher increases in HDL than some of the other statins out there. They have the best LDL lowering potential of all the drugs, and specifically rosuvastatin and atorvastatin are the two most potent statins out there. And the current ones that are brand name only are still rosuvastatin and pitavastatin. So all the other ones have gone generic. So you do have a generic high potency statin in the brand name Lipitor, which is now atorvastatin generic, which has brought costs down substantially for a lot of patients, which is always nice. So back to evidence a little bit. There's a ton of studies out there. This just shows some of the early studies, some of the bigger trials, and a little compilation of some of them, looking at drugs like simvastatin and pravastatin when they're first on the market, some of the older statins, and their reduction in LDL. So you can see their baseline number of people in the studies, pretty decent sized trials, lots of patients, and we have pretty decent reductions. So you got anywhere from 20 to 35% in reduction in coronary events, in the 20s to 30%. Number needed to treat, pretty good numbers too. So that means treating 15 patients, you're going to prevent one coronary event. That's pretty good medicine if we can prove that consistently. Some of these not quite as impressive, like pravastatin 40, 28, 42 for the pravastatin 40 here. But again, are these the drugs we're using today? Not as frequently. So there's a trial called Jupiter, which stands for Justification for the Use of Statins in Prevention and Intervention Trial Evaluating rosuvastatin. I always wonder if they make the name up first and then they try and figure out how to put the letters in, or if they title it and then pick out random letters. It's hard. Where did they get all the letters from? Anyway, I just think it's kind of funny. I want to be the person who names clinical trials. Somebody gets paid a lot of money to do that, probably. But it's catchy, right? It's the Jupiter trial. It must mean it's big. So it showed significant cardiovascular event reduction and reduced all-cause mortality. And the interesting thing about this study is they targeted people with a CRP greater than 2. You guys have talked about CRP at some point, I'm assuming, right? Some biomarker of inflammation. Not commonly used in a lot of adult medicine. It's a much more common pediatric thing they use in sepsis and stuff like that. But they looked at this as a biomarker thinking of general inflammation. And rosuvastatin versus placebo was measured, or were given to the patients, and suggested benefit patients with increased levels of inflammation. So the patients with a high CRP actually responded better and had positive reductions in all-cause mortality from the rosuvastatin group. And this was a pretty big study. This is one of the first big trials out there that said, yeah, let's not even look at cholesterol and just give people drugs and see what happens. They probably looked at LDL as a secondary outcome and looked at those two to see, what the difference were between the two groups. But the point was, and to skip it down a little bit for you guys, is that it was really focused on inflammation and all-cause mortality, and those are the two things that they looked at, with the drug being the differentiating factor. Prove It was a trial that looked at high-dose atorvastatin post-ACS compared with standard pravastatin and saw a 16% reduction in death or major CV events. This is one of the big trials that came out that led us to change our practice guidelines, that people post-ACS get started on high-dose, high-potency statins, where previously they started on low-dose, low-potency, and the idea was like any drug, you'd start low and tend to work your way up, watch their LDL levels, and target a goal level. Again, now we don't really care about the goal level, so we start high with high potency, and the evidence out there so far says that that's better to do. You're going to get better outcomes with that strategy. This is a big table that compares all the current statins on the market, and as far as knowing this, I think what I really want you to understand are a couple points. And first of all, knowing that atorvastatin and rosuvastatin are the high potency ones, so just like we talked about in the fall. Half-life wise, it doesn't really matter. Most statins are taken once daily regardless of the half-life. They seem like, if you look at pravastatin or simvastatin, the half-life, its elimination is only a couple hours. They're still once daily drugs. It's thought of that statins don't need to be in the body continuously to prevent cholesterol synthesis. They can do their work, they can irreversibly inhibit the enzyme, and then they get eliminated whatever drug's not being used. So ultimately, it just doesn't matter. Clinically, we don't really care about the half-life. Solubility is kind of interesting, and whether it's lipophilic or hydrophilic has been something that's been of debate recently. So there's some, we're going to talk about side effects, but there's some ongoing discussion that statins might contribute to things like Alzheimer's disease chronically. So we've had statins around for quite a while. We're starting to get to some of the first people who started statins getting into the elderly phases of life. And so there's a theory that the more lipophilic the statin is, the more it can get into the central nervous system, and the more likely it could be to potentially cause CNS toxicity long term. Now, a lot of this is really theoretical, so don't take this to the bank or anything. But I'm just pointing this out because there's some evidence around pravastatin and rosuvastatin being hydrophilic statins, thought that they don't get into the central nervous system as readily as their counterparts, therefore you don't get as much CNS effects. So I think I had a student last year saying, well, if you had a young person who needs a statin, would you recommend one of those? You might. Again, there's not enough evidence to really say that that's a firm recommendation, but logically, if you are buying into that statins have some CNS toxicity, and we'll talk about that in a second here. I'm a little bit on the fence whether it's actually a real side effect or not. I don't think the evidence is fleshed out enough to make that decision, but it is an interesting point to mark out, I think. What else? Food, active metabolites, not really care about that. Optimal time of administration. A lot of people take their statins in the evening, and the reason is because the first couple of statins that came out were shown to be more effective at lowering LDL when taken at night because your body synthesizes cholesterol at night. So the idea is you take it at dinner or bedtime, and as your body's synthesizing cholesterol while you're sleeping, you can block it at its most optimal point in synthesis. The current statins that we use, like the newer ones, I should say, like atorvastatin and rosuvastatin, for example, are long enough acting where it just doesn't matter when you take them. A lot of people recommend taking them at night anyway. There's not a whole lot of evidence for those two drugs specifically. Again, there is maybe some more evidence for something like simvastatin being more effective at night. So if you're going to give an older statin, shorter acting, probably at night is best. But the other ones, if they want to take it in the morning with all their other meds, if that's most convenient for them, go ahead and let them do that. Statins are not really renally excreted to a point where we care. You don't have to renally adjust them. So that's a nice advantage of them class-wide. Here's all my brand names, so I haven't put these on specific slides, but in case you're wondering what all the different brand names are, they're on here. All their nice marketing and advertising, you guys. And a funny slide. This was an Italian ad for fluvastatin, and they took a lot of heat for this, the company. You can probably see why. They're basically advertising that, yeah, you can eat whatever you want, and you can take a statin, and it's going to make everything okay. So whatever Italy's FDA equivalent was not happy with that advertisement. This just shows what we've already talked about, but it puts a numerical value onto the percentages of LDL lowering. So again, our highest percentage lowering effects from atorvastatin and rosuvastatin. And you can see some of these other drugs don't even compare at their highest dose to rosuvastatin's starting dose. I mean, comparatively, yeah, they're pretty close. what I'm saying is even if you give somebody a little tiny dose of Crestor or rosuvastatin, you're still trumping the majority of these other ones, even at their max doses, which is pretty impressive. So a lot of times what you'll have is if you have a patient who's really sensitive to statins, they might get muscle pain but maybe they can tolerate low dose. You'll see Crestor used often as the low dose drug of choice because it's so potent even at small doses. Lipitor or atorvastatin is similar. It's still got pretty high potency. It's a very flat curve. You really don't get a huge response as you go up. It starts, same with Crestor. It's a little bit more aggressive though. All right, so probably the most widely prescribed drugs in the world. Very good safety record overall. Again, when we talk about drugs like this and drugs like lisinopril and just really common things like metformin, when we talk about medications that so many millions of people take, every side effect instance has to have a lot of people that have it in order for it to have any type of statistically significant data behind it. So hepatic dysfunction was one of the early scares of statins. And when I went to school, they told me that it was common practice that you would test liver enzymes regularly while somebody's on a statin. That's pretty much fallen out of favor. It's been relatively well proven that statins do not increase the risk of hepatotoxicity more so than placebo, and that the general population would do. So there's done a lot of meta-analysis to look at that, and that's pretty well established. Now, if you do get hepatotoxicity from statins, it is thought maybe there is still a link there, and it would happen within the first 3 months of therapy. It's usually dose dependent. So where I'd see this happening is a patient who's starting on a high potency, high dose statin. That might be the highest risk group of statin users to experience this, but still very rare even among those patients. It is recommended monitoring, so baseline labs is probably a good thing to do. So before you start a statin, just check their ALT, AST, make sure that nothing looks out of whack, and then you'd only recheck if clinically indicated. So if they exhibit signs of jaundice or other things like that might indicate hepatotoxicity. If you get persistent elevation on it, that would be required to be 3 times the upper limit of normal for 2 occasions. That's ALT specific. Then you'd either decrease the dose and see if that resolves the problem, or change to a different statin altogether. It's thought that it's not necessarily it's thought as a class effect, but some medications get metabolized by different enzymes. So the idea is that you might be able to get by with one that doesn't affect the liver quite as much as a different pathway. It's worth a shot, I think. Memory loss. So this is what I was getting at. That's not really well proven, but theoretically possible. So if it's something you're interested in, I'd recommend looking into it more. I'm not going to talk about it again because there's just not enough evidence to give a conclusive discussion on it, but it is something that people are looking at. It's something I read that comes up a lot where somebody's like, oh, I thought statins contribute to Alzheimer's disease. Well, there is actually some counter evidence that says statins prevent Alzheimer's disease. So there's both sides of the coin there. Diabetes, this is another one that's come up, that there's an association between increased risk of diabetes with statin use and exacerbation of diabetic states for people who are pre-diabetic or currently diabetic taking statins. I don't really know why this would be the case or what the association is, but there seems to be a statistical correlation between the two. Whether it's related to the drug or more so why the people are taking the statin for their baseline disease, I don't know exactly. But that's something that, again, is further research might help flesh that out, but we don't really know enough right now at this point. All right, myalgia being our biggest concern and most common complaint. It's a 2 to 11% incidence. We want to rule out any other causes immediately. So if somebody's got some sort of musculoskeletal thing going on, that's something we want to make sure we get that ruled out. Lab value, elevated serum creatinine kinase is going to be the primary biomarker here. The drugs that have the lowest risk are thought to be pravastatin and fluvastatin, being 2 of the lower potency statins out there. Sometimes this is thought to be dose related, so decreasing dose might help with that. I've seen people take statins once weekly or every other day because there's a concern of muscle risk. And they get somebody on a low dose and it finally works, but they don't have muscle pain. Whether it's placebo or not at that point, I'm not exactly sure. Sometimes, again, thought to be dose related, so you might see that help. Drug interactions. So this is a big one that I think could actually be probably one of the largest influences in causing myalgias for people on statins. Most of these are CYP metabolized, so anything that's either interacting with that by interfering with the pathway and competing for the pathway, or inhibiting that pathway and increasing your blood concentration of the statin can give you risk for increased myalgia. So Simvastatin is one of these ones that's pretty prone to drug-related interactions. It's CYP3A4 metabolized, so there's a lot of things that compete for that pathway. And it's been shown that there's a lot of dose reductions that can possibly decrease risk of myalgia. So, for example, amlodipine or Norvasc for calcium channel blocker for blood pressure is a really common one that interacts with simvastatin. Very popular medication, both of them are. So, simvastatin has very specific dose reduction, so you don't really go over 20 milligrams a day when somebody's on amlodipine. There's a lot of references out there that will tell you what to do with that, so I'm not going to go into more detail than that. But just keep in the back of your head that if you have somebody on simvastatin, that's probably the biggest one to consider for these drug interactions. On the flip side, pravastatin being the least potential. So pravastatin has least metabolic interferences with it, and it's the one we use for patients who have a lot of other drug interactions to be concerned about. It's our go-to medication. Even though it's not as potent, it's still thought that it's better than no statin at all. Rhabdomyolysis and renal failure would be the two major serious complications associated with this. Generally, this isn't going to affect somebody substantially other than it's going to make them uncomfortable and in pain. We can remove the drug and hopefully reverse the problem or change the drug or reduce the dose. In some rare cases, people can proceed to full-out rhabdomyolysis, which can cause a really huge spike in serum creatinine, and ultimately, as that stuff's trying to get filtered through the kidneys, all the muscle breakdown products, you can get renal failure. You can also get hyperkalemia as well as potassium leaks out into the serum. So there's some complications with that. Rhabdomyolysis is a true drug-related side effect is pretty rare in itself. Myalgia much more common, but they're totally different. All right, so managing myopathies. Hold the statin, wait for CK to return to baseline symptoms to resolve, check for drug-drug interactions, see if there's some dose adjustments that need to be done. Hypothyroidism has been associated with statin myopathy, so we can correct that if needed. Vitamin D deficiency has been associated with statin myopathy, so correcting that as well. There was a theory that coenzyme Q10 had a role in muscle energy, well, it does have a role in muscle energy, or muscle cell energy production. Your body produces coenzyme Q10 naturally, or uses it, and statins may decrease your body's ability to produce it. So there was a thought that if you supplement CoQ10, you can decrease risk. They've done some studies looking at this, and the treatment for prevention has been lacking. So we haven't really seen supplementation be advantageous for people in preventing myopathy versus people who don't take CoQ10. If your patient feels better about taking it and they want to, it's a relatively benign treatment. Deciding who needs a statin. So again, controversy over your new calculator. Guidelines, like I said. A lot of patients will be resistant. Well, not a lot. I should say some patients might be resistant to taking a statin. They say, well, I live a healthy lifestyle. I diet and exercise. I'm a vegetarian. I eat hardly any cholesterol in my diet. Those are things that have come up, and I actually have an aunt who has all those things. She's very healthy, very active, but she's just got genetically high cholesterol, so she takes a statin. And I don't think she's totally okay with it, but she's bought into it. So you just get people that, for whatever reason, they're still at risk even after their diet and lifestyle. And so I think it's the importance of being able to explain that to patients and allow them to help them out to make that decision. You don't have to push statins on people who really don't think they need it, but there are patients out there that can benefit that still might have pretty healthy lifestyles on top of it. Which statin? So generally the three you're going to see used are Simva, Atorva, and Rosuva, with Atorva and Rosuva being the two most popular ones. Usually insurance can't pay for rosuvastatin. It's going to recommend the patient take atorvastatin. Both high potency. Atorvastatin is just less expensive. Genetic testing. This is on the future, what am I trying to say? On the horizon in the future, and you have the idea that people could get different polymorphisms that metabolize the drug differently, and if we can test for that and identify that early, we might be able to pick the right statin for that patient that's going to get metabolized the best through their body system. But that hasn't really panned out for statin testing quite yet, but I'd imagine it would be something we see in the relatively near future. I just put this up there as a random drug article I pulled. There's always these stories out there that are for a lot of different medications. Statin's not exclusive to this, but that come out and it's like a news article. Do cholesterol drugs really do any good? Why are we giving these? The benefits are overstated. Okay, a lot of this is sensationalism media, I think, but there is some thing to say that, yeah, maybe we overuse them. Maybe we tell patients that, I think it's important to be realistic. But there are big mortality benefits that are documented. Now, 30% mortality reduction, is that enough to like make a difference in a patient's mind who's not maybe health literate or statistically literate? I don't know. That's just something that would need to be decided by the patient, by the provider. But you do see all these articles that kind of try and stir the pot a little bit. You also see the flip side of the story that says, should statins be put in the water? Should statins be given to everyone? Should be over the counter? In fact, I put this up here. England, or the UK, I should say, has simvastatin as available as 10 milligrams as OTC. So you can actually self-medicate with statins in the UK, which is interesting. I don't know if I think personally it's a medication that would qualify as a self-diagnosis type of a thing, but they apparently think it's safe enough where it's okay to use that way. So when we move into these other drug categories, I'm going to touch on them briefly. I'm not going to spend a lot of time on them because really they don't have a huge role in therapy anymore. But this is a comparison. So if you look at statins topping out at LDL reduction, 60%, the rest of these just are not going to reduce things all that much. Omega-3 fatty acids, interestingly enough, if you take a ton of them, they do drop your LDL, but they also increase your triglycerides a lot. So it's a little bit of a trade-off here. All right, fibrates. So fibrates are rarely ever used as monotherapy. They're triglyceride-lowering agents, and the only time we use them is when people's trigs are really high to start with. So usually you're looking at triglycerides like over 500, which is pretty hefty lab value to see. I put this calculation up here because the way a lab will calculate your LDL is based on these values. So it measures your total cholesterol, your HDL, and your triglycerides, and then it divides the trigs by 2 and subtracts. So if your trigs are really high, you get a negative number here, and of course that doesn't make any sense. So your trigs have to be below a certain amount. I can't remember what the cutoff is. It probably depends on the lab. But if your triglycerides are way outside of normal range, you just won't get a value that makes any sense. Mechanisms. So these are activate the proliferator activated receptor alpha, which is a PPAR alpha receptor. And this results in lipolysis and elimination of TG-rich particles from plasma and may increase synthesis somewhat of HDL. There's not a lot of mortality data behind this, maybe some reduction in CV events. But high triglycerides and low HDL patients in that specific study were shown to benefit from it, which makes sense with this drug. A lot of times you'll see this just as an adjunct to a statin. The two drugs are gemfibrozole and fenofibrate. Either one is usually okay. Fenofibrate's better for patients with renal dysfunction, has less side effects overall. You have some hepatotoxicity, myalgia risk with gemfibrozole, so adding that on top of a statin might make people a little bit worried. Fenofibrate has a better side effect profile overall, but they're both fairly effective at doing the same thing. But fenofibrate was brand name for a while. They're both generic now, so both of them should be relatively affordable. Niacin or vitamin B3 was one of the oldest lipid-lowering drugs used, one of the first available at a prescription-strength product. It's basically the same niacin you would buy in a B3 supplement, but the pharmaceutical products are tested and proven to contain that amount of product, and they're higher dose than what you'd see with an OTC product. Best drug we have for raising HDL. They decrease hepatic production of VLDLs, which inhibits free fatty acid, and then that maintains the structure and function of HDL. Increasing its longevity, basically. Formulations, long-acting, are better tolerated. People tend to get flushed on niacin. It's one of the biggest complaints with it. So the products that are most commonly taken are either the prescription one, which is an extended-release product that decreases that instant absorption, helps you maintain a steadier state, which decreases the flushing. Slow niacin is an OTC product that is a controlled release as well that helps decrease that side effect. Other things, hyperglycemia and hyperuricemia, so people with gout can be at risk for flares with this. Rare hepatotoxicity potentially, and contraindicated with high-dose statins due to increased risk of myalgia. So actually, you shouldn't even take this if you're on a max-dose statin, which kind of, again, limits its role in therapy substantially for a lot of patients. Bile acid resins or sequestrants, very unusual to see these used anymore. The only time they are okay in pregnancy. So maybe in a statins, I don't think I have this on the slide. The statins are category X in pregnancy. They're contraindicated. So if you have somebody at really high risk or really high cholesterol and you want them on something, you might consider this. But that's really the only, I think, clinically applicable area where you might use it. Problem is they're just, they work in the GI tract. They aren't very well tolerated from people. People tend to get GI-related side effects with them. And you have to take them multiple times a day as well. Zetia or ezetimibe, as the generic, is a cholesterol absorption inhibitor that works in the intestine to block intake of excess cholesterol. The theory behind it is really great, right? You block intake of cholesterol with your Zetia, and you block the synthesis of new cholesterol with your statin, and you should get a much more synergistic approach to cholesterol management. The trials out there are a little bit controversial. So Vytorin, some of you guys might have read this for your forum post, but Vytorin was the product that came out on the market and combines simvastatin with ezetimibe. Ezetimibe is available by itself too, and it is generic now, so it's relatively affordable if you wanted to prescribe it. But the trial that originally looked at this combination showed that the product wasn't better than the combination, or simvastatin alone wasn't better than the combination. So that meant that why are we prescribing an extra drug, and at this point an extra more costly drug for no real reason? Now, the interesting thing is that even though it lowered the LDL further, the mortality benefits were flat. However, they restudied this recently with an add-on trial and looked at the data again and looked at a new subset of data and actually found that there was some mortality benefits. So we have two conflicting pools of evidence, one that says you don't get any benefit from adding Zetia, the other one that says you do. I can say from a clinical perspective, I don't see this medication used a lot, so I don't think that it's caught on, but I think it's one of those where we have a mixed group of evidence. We need some more studies before we're going to adopt this more widespread. Side effects are pretty rare. GI symptoms and muscle aches. Muscle aches probably due to people taking statins with the drug, but you don't know that for sure. It's hard to tease that out in a clinical trial when you're studying it in conjunction with statins. I say it's not generic on here, but it actually has gone generic recently, so you can change that. That's a relatively new change. But and then finally, the PCSK9. Most of you guys probably read enough about these to get a good feel for how they're used. And nothing's really changed since the fall, as you might expect. These are still expensive. They still have a niche market out there. Two major drugs, sub-Q injections. These are monoclonal antibodies, so they're biologic products. And 2 weeks or once a month. Potent LDL reduction, so it's monotherapy up to 60% reduction. And in addition to statins, 60% reduction on top of whatever the statin's doing. So pretty decent numbers right off the bat. And the evidence for them so far has been shown to be decent as far as the mortality benefits. So we're seeing some good preliminary data come out with these, but the problem is they're really expensive. And so I don't think they're ever going to jump onto being the primary drug, just unless some sort of monumental trial comes out that says they're really this much better than statins. We just don't have that evidence yet. Where they are good for are familial hypercholesterolemia. So patients with familial hypercholesterolemia are historically extremely resistant to statin lowering effects of LDL. Some patients will respond just fine to statins, but some you can't get it down no matter what you're on. Your LDL is still high and you're still likely at risk. So PCSK9 inhibitors work a lot better in those patient populations for getting the LDL down. So if your patient's one of those above 190 for the guidelines and your statin's not touching it, this might be the drug to try. Statin intolerant hypercholesterolemia, people who have tried every statin under the sun and they still get myalgia. That'd be basically your person there. Or maybe somebody who gets hepatotoxic with statins. Or really high-risk patients. This is more of the questionable group. So if you're high, the first two, you don't really have another option, right? If you're not responding to statins because you've got familial hypercholesterolemia or you're intolerant, there's not really anywhere else you can go. If you're a high-risk patient and you're already on a max dose Crestor or atorvastatin, it's a question of, do you really get an added benefit from this? And yeah, you might get some added LDL lowering, but does that really give you long-term mortality benefits? So that's some of the questions that I think need to be answered with PCSK9. I think the early evidence would say yes, but there's still some work that needs to be done. I showed a couple of the largest meta-analysis on there that showed a decrease in all-cause mortality without increase in adverse effects, regardless of indication or concurrent statin use. So again, decent evidence coming out initially supporting these medications. So, but they're new. We haven't really seen long-term effects with them like we have with statins. If you're on a statin already, these are some of the preliminary numbers for reductions. Again, small amounts of percentage, but when you're looking at big pools of people, possibly decent numbers. If you're looking at reducing CV event reduction by 1.5 points or so, depending on what study you look at, that could translate to huge cost savings for the U.S. healthcare system. So is it worth spending a lot more money on these medications to give them to people to reduce a few events here and there? I don't know. That's, again, where we need to get more evidence and more, probably a more in-depth financial analysis on whether that's appropriate or not. So again, expensive. There are some trials looking at statin intolerance and using these medications that had some misleading data that these drug companies got criticized for right off the bat. So I think they've cleaned up some of their data and their trial approaches, but there was some initial controversy with, well, statin intolerance, we weren't really showing the benefit like you guys claimed we were. Lowering LDL alone, again, has a mixed group of evidence. We know that's not the only thing that affects CV outcomes, so that's another questionable thing. And unknown long-term benefits or side effects. So these drugs are interesting because they really lower LDL to an unprecedented standard. So there's some studies that showed people are getting into the 20s for their LDL. If you checked any healthy person, their LDL should be 70 to 100, somewhere in there. So even somebody who's really young, in shape, eats great, their LDL could be 70. That's fine. We don't really care about that. But what if we have somebody chronically with an LDL of 25? What does that mean for them long term? Don't they need that LDL, some of it in their body, to do something? And those are the questions that have come up with these preliminary data with these trials. There was a big scare originally that these are causing a neurocognitive deficit. There's like a 1 to 2% incidence of this originally, and since then they've kind of pulled back on that and said that we don't think that's a problem anymore. Based on some of the more later evidence we found as our post-marketing analysis. But it's still something I think that's being watched pretty carefully with these. And there's some oddball side effects. Increase in respiratory tract infections. Why? I don't know. It must be having some interaction with the immune system, but I'm not exactly sure, and I don't think we fully understood why that causes increase in URIs. So, but get your flu shot, get your pneumococcal vaccine if that's appropriate for your patient populations if you're going to be on these drugs. All right, primary versus secondary prevention. Primary diet and lifestyle should always be considered, even though we know that might not be the best strategy for all patients. It certainly can't hurt most of our patients out there. Take all risk factors into consideration. Don't force your patient on a statin. You don't have to push statins on everybody, but have an intelligent conversation with your patients about what the guidelines recommend. So let's say you start a patient on a statin, and you recheck them, and their LDL's not above 190 anymore. It's come down, maybe it's 150. So what do you do? That's a big question mark right now. So we're so used to managing numbers with this, and then all of a sudden, do we care about that anymore? And technically, you don't really care. It's not really worth adding another medication per our current guidelines and per current body of evidence. You just keep them on the statin. You can increase the dose if you can tolerate it, if the patient can tolerate it, and you can go up on the dose of your current medication. And if they don't tolerate it overall, to increase the dose, you could just try and focus on what dose you can get by with and maybe add lifestyle benefits on top of it, or lifestyle modifications. Check LDL after 6 weeks of statin therapy and then maybe every 6 to 12 months thereafter. Some people argue you don't really need to check it any more than that. But the theory would be if you're on a low or moderate dose, if your LDL creeps up and gets above that 190 mark again, then you're at substantial risk and you want to try and knock it back down. So that would be the reason. Secondary, so similar to primary prevention, statin therapy almost always indicated post ACS and for patients who have heart failure. So secondary prevention to prevent other episodes and for people to get some sort of a cardiovascular event. So looking at high dose statins and high potency statins, that's again the biggest thing. All right, just so to summarize a little bit, high cholesterol, high risk, secondary prevention. So these are your people over 190. They're maybe fall under, maybe they have diabetes or something like that, some comorbidity, but you want to treat them with a high potency statin. If you're targeting an LDL goal and the max statin doesn't cut it, you could consider adding something else. So let's say, again, you're trying to get them below 190. Let's keep using that as our number here. Or maybe you like the old guidance. You know, I think there's enough good evidence to say I should be below 130 that makes sense for me as a provider. You could make that argument relatively logically. I mean, that's the way we practice for a number of years. So let's say you want to push them down a little bit more, and your patient's open to it. You could add on ezetimibe would probably be the best choice to get the LDL down a little bit more. The rest of the drugs, niacin might lower it too, depending on which drug you picked. If you're on a high dose, high potency statin, that's not going to be an option. If they have really high triglycerides, remember fibrate therapy needs to be done, needs to be added. If your HDL below 40, I would put a star or question mark behind this because this isn't a really good recommendation, but it comes up. What do you do? HDL is not really very responsive to medications. You could put them on niacin, but I wouldn't have that trump a statin if they are qualifying for a statin. So I always use the statin first. HDL, from my experience talking with clinicians and doing some outpatient rotations and things like that, I'm a little bit rusty on some of this, but HDL does respond a little bit better to dietary modification and changes than LDL does. So things like exercise tends to increase HDL. And there's been some studies that show that actually is a pretty effective way to bump up your HDL, more so than a number of the medications that are out there. So again, lifestyle can help bump that HDL up, which can theoretically reduce your risk a little bit at the same time. All right. Any statin questions? Cholesterol questions? No? All right.